in today's scenario. There's a huge diaspora here, right from diagnosis to obturation. There have been innovations and changes in each and every sector. To enlist a few, radiographic diagnosis has been supplemented with endo scans, which is also called CBCT, the cone beam computed tomography. These days, no repeat root canal is complete without having a pre-operative or a diagnostic endo scan done. Access designs have been modified. The shaping protocols have changed. The shaping protocols are predominantly dominated by the rotary shaping protocol, as we all follow it.
Little louder, please.
Louder? Yeah. The shaping protocols, as we routinely follow them, are dominated by the rotary shaping protocols as we know them, involving rotary nickel titanium instrumentations. The cleaning and irrigation protocols have also seen a sea change, whereas related to the delivery systems as well as the irrigants used. Obturation in 3 dimensions is the way to go. Microendodontics, record keeping and assistant training, all of this has undergone change. In today's webinar, I have designed it in a way that I'm going to give you certain bullet points related to the major changes that we see in today's scenario as far as root canal treatment is concerned in the modern scenario. Bullet point 1. I have compiled a few bullet points which will definitely highlight the major changes that we make in today's protocol of modern endodontics. As enumerated earlier, in the radiographic diagnosis and CBCT endo scans, the bullet point 1 that I would like you all to take note is start taking angled radiographs. We have been so used to taking radiographs in the regular angles which show us the image in a mesiodistal dimension. This has its limitations. Let me tell you what is the advantage of the angled radiograph. I hope all of you can see the radiographs on my screen here. Dr. Praveen, is the image seen?
Yeah, very nice, very nice.
Very clearly. So, in image 1...
Voice is low, you can be little louder.
Still louder?
Yeah.
Okay. Let me raise the volume. Is this better?
Much better.
Okay. So coming to a bullet point 1, wherein I have recommended that all of us should start taking angled radiographs instead of the regular radiographs. Now what is the difference here? What do I mean by an angled radiograph? An angled radiograph simply means taking the tube which is angled towards your X-ray film and moving it 20 degrees either to the mesial or 20 degrees to the distal. In the mandibular arch, I prefer to move the X-ray tube 20 degrees mesially. This is called the mesial angled radiograph. What you see in the image right now, the image number 1, is a working length radiograph. You can see 3 files distinctly in the 3 root canals. I want you to focus upon the mesial root. If you see the mesial root of this mandibular molar, you can see the 2 files very clearly, separately in the mesiobuccal as well as the mesiolingual canal, which otherwise would have been overlapping each other. How was this possible? Simply by moving the X-ray tube 20 degrees to the mesial when taking this radiograph. Advantage of this technique, you get to corroborate your correct length in each and every canal without having a CBCT taken. Even on a radiograph, you can measure the radiographic working length accurately in each and every canal, whether it is mesiobuccal or mesiolingual. The second radiograph that you see on the screen is the obturation radiograph of the same patient. Again, I can say, you can see that the Gadapacha point has reached the working length in both the mesiobuccal and the mesiolingual as clearly seen on the radiograph. When you move the tube towards the mesial, the canal which moves towards the mesial is the lingual canal. This is applying the slope rule. Another example of the mesial angulation in mandibular molars, here the mesial angled radiograph has been taken to aid diagnosis. Look at the radiograph 1. When we took a head-on angle, the radiograph 1 is the regular head-on angle. In the head-on angle, we could sense that there is something very different about this tooth which had been referred for a root canal to our practice. We can see a target eye lesion here on the distal root. In order to gain more information, we took a mesial angle radiograph again, a 20-degree mesial angle. And look what we see in the radiograph 2. Immediately, the extralingual root, distolingual root, has shifted away from the regular distal root. This was possible simply by taking an angle radiograph, and look at how much extra information is now available to you right at the stage of diagnosis. Since this is a mesial angle radiograph, the root which moves mesially, as you can see, the root which moves mesially is the lingual root, whereas the root which has moved distally is the buccal root. So, the one extra root that I see here is the lingual, the distolingual root, and then you also have a distobuccal root. So, we made this diagnosis right from the X-ray itself that this is a case of radix entomolaris with an extra distolingual root. Having this information right at the stage of your diagnosis will go a long way in helping you plan your treatment successfully. So my bullet point, start taking angled radiographs, especially in multi-rooted teeth in the mandibular and for the multi-rooted premolars where the buccal and the lingual or palatal roots overlap each other otherwise. Coming to the next valuable diagnostic tool today available to us in modern endodontics is the endoscan, the endodontic scan, or the cone beam computed tomographic scan, CBCT. I'm going to share two cases with you for different reasons. What you see on my screen, can you see a CBCT endoscan on the screen?
Yes, yes.
Hello?
Yes, you can see.
Okay. So it is seen. So if you look at this endoscan, what does an endoscan show us? It shows us sections which are taken horizontally. It shows us vertical sections and gives us the missing third dimension. In this particular patient, there was no evidence of caries, and still the patient had a buccal sinus clinically in relation to 1-7, tooth number 1-7.
Ma'am, please.
Radiographs. Yes?
Please go for full screen.
Full screen? Okay.
Yes. Please proceed.
Is this better?
Yeah, better.
Okay. So in this patient, what was the additional information that I gave? Why did I order an endoscan for this particular patient? Coming back, tooth number 1-7 showed a buccal sinus, a buccal draining sinus, which was traced to tooth number 1-7 on the radiograph itself. However, there was no evidence of caries and no conclusive history. I wanted to be sure that this sinus is definitely related to tooth number 1-7 and wanted to know where exactly the infection was localized, and so we ordered an endoscan for this tooth. As you can see in the first image, you can very clearly see three canals. You can very clearly see three separate root canals in tooth number 1-7. You can see in the image in the last line, the second image in the last line, a radiolucency well defined between the palatal, the mesiolingual, the mesiobuccal and the distobuccal roots. You see the extent of the radiolucency from between the two buccal roots extending towards the palatal root, giving me an idea that definitely this lesion is associated with 1-7 and an infection which is very much present in the furcal area of this tooth. Having established this, we plan the treatment plan of going for endodontic treatment with 1-7 for the tooth. And you know what? When I opened the access in this tooth, the tooth turned to be non-vital. So we could achieve exact correct diagnosis with the help of an endoscan in an otherwise inconclusive tooth. Moving on to the second case. This second case was referred by me for an endoscan. This is a repeat root canal case which showed good quality obturation on an radiograph. However, the patient clearly had symptoms of tenderness and also shows furcal radiolucency on the radiograph, suggestive of a failing root canal. Earlier, we would have to scratch our brains to know what could have possibly gone wrong. We would have to open the tooth, check each and every canal, and then arrive at a diagnosis. With the endoscan available today, we can arrive at a probable diagnosis looking at the scan images itself. If you see the image 1 in this CBCT, you can see the MB, ML and the distal of this molar, mandibular molar, well obturated in 3 dimensions. You can see that it is well obturated at each and every level. See the top 3 images. However, when you see the other image, very clearly you can see a furcal radiolucency between the MB and the distal. So also a perforation in the floor of the tooth in the image 1 and in the image B in the lower line, which is marked by the arrows. So what I could gather from this image, that there was a perforation in the furcation area. So also there's a strip perforation because of over preparation of the root canals, over preparation by rotary instrumentation, which is causing failure of the root canal treatment. So I know that I can probably expect a furcation involvement here, a furcation perforation and strip perforations related to the coronal aspect of the mesiobuccal and the distal root canals. So much information is available today even before I begin the root canal treatment. So the CBCT can be used to our advantage in modern endodontics. I recommend, my bullet point, I recommend a CBCT endoscan for every repeat root canal case so that you know what canals have been missed, what could be the probable reason for the failing root canal. I would also recommend an endoscan for difficult or inconclusive fresh cases that come to your clinic for root canal. Bullet point 2 in today's presentation is related to your access cavity. Access cavity, the orphan in modern endodontics. These days, modern endodontics is synonymous with rotary endodontics, but I believe it begins right in the beginning with modifications within the access cavity. I am going to share one simple modification in your access cavity which will make your subsequent rotary protocol very, very easy. This is called the Matka to bucket access cavity. What do I mean by this and why am I using the Hindi language here? It's simply for me to remember and to get the point across. What do I mean by this? The image 1 that you see is that of an earthen pot. How is the earthen pot? It has a nice round opening, but look at the base. It's wider at the bottom and the opening is narrow. This is how most of our access cavities are made. We can see the orifices, yes, but the narrow opening of the access cavity and the broad base always creates a large area of resistance for the rotary file to follow within the access cavity itself. What is the shape that I am looking at? I am looking at the shape of a bucket which has a very broad orifice or opening and a tapered base. Applying this principle to a tooth, what do I get? Simply said, what I get is a straight line axis. A straight line axis for rotary endodontics is extremely important to avoid instrument separations or breakages right at the orifice level or the coronal to middle third level. This can be simply achieved by removing the calcification which is often present at the level of the orifice, the lip of dentin that you find, the secondary dentin deposition that you find at the level of the orifice itself. Many a times when you introduce your files into the orifice, they stand off axis. We need to remove the triangular lip of dentin to get the file to stand on axis. When I say stand on axis, I mean a straight line axis up to the middle third of the canal or up to the point where the canal curves. This is how you convert the Matka into the bucket, or this is how you convert a constrictive access cavity into a flared access cavity. You need to, this is the triangular. Image A shows the approach. Image B shows the depth and the width to which you need to expand your axis. Normally, we feel that image B is an adequate axis in itself, but that's not the case. The pointer is pointing at the triangular lip of dentin, which is going to exert stress on your rotary file right at the level of the coronal third area. The one bullet point tip I want to give you is remove this triangular lip of dentin with a safe ended tapered fissure burr to get a safe tapered cavity. So this image 1 on your screen shows an inadequate axis. Though I see the orifices, the axis is inadequate because the opening is narrow and the base is broad. Flaring up this axis cavity with the help of a safe-ended tapered fissure allows the rotary instrument to enter into the orifices without restrictions from the walls of the axis cavity itself. So what is the addition to investment or addition to an armamentarium that I need to make? Simply said, just one word. The safe-ended tapered diamond point or the safe-ended tapered burr to flare out access cavity walls. A small investment which will give you big rewards in the long run. Bullet point 3 of today's presentation is related to orifice location. Today is the era of microendodontics, and magnification and illumination have a great role to play in location of the additional canals. We find so many new and smaller canals today than we used to long ago simply because of the advent of this one thing in our practice. So does that mean I need to have, is it a must to have an endodontic microscope in my practice from day one? Not necessarily. Your loupes, magnifying loupes, can do the job for you until the time you have the money for investing into an endodontic microscope. What is the benefit of using magnification like loupes in your practice? The elusive canals, which are normally not seen by the naked eye, will be very clearly visible using magnification. Magnification is one, and the second investment is a simple chipping tool, as I call it, and it's called the DG16 probe. Now what's a DG16 probe? The DG16 probe is simply said a double-ended probe with 16 millimeter length and a sharp tip which helps in accurate location of the canal orifices. especially in calcified pulp chambers. How does it help? Moving the DG16 probe along the dentinal mat or along the predicted anatomy will help to engage the orifice with the tip of the probe. Once the DG16 probe engages the orifice, you can go about enlarging this orifice sequentially with the help of your hand instruments first and then your orifice openers later. So addition to investment is a simple DG16 probe. How does this help? I'm going to show you two cases here. The elusive MB2 in the maxillary molar. Many a times we do not find the MB2. A lot of hue and cry has been raised about the MB2, and now it need not be so. It's very, very simple. This diagram represents the position of the MB2. So how is it located? The MB2 is located on a line joining the mesiobuccal to the palatal, slightly towards the mesial and closer to the mesiobuccal. It's called MB2 and not palatal 2, meaning that this is the orifice located beneath the mesiobuccal cusp of the maxillary first molar. The principal mesiobuccal orifice is located under the tip of the mesiobuccal cusp as seen here. Little away from the mesiobuccal orifice principal, slightly towards the mesial, is the mesiobuccal orifice. If you look at the real diagram of a tooth, real picture or image of the tooth, if you've located your palatal and if you've located your MB1, draw a line joining these two. Slightly mesial to the line joining the palatal and the mesiobuccal 1, closer to the mesiobuccal 1 is the mesiobuccal 2. So what is the modification in access cavity that I recommend? Your access cavity cannot be strictly triangular, but has to be slightly rounded triangular towards the mesial in order to accommodate the additional MB2. How do you locate this when it is not clearly visible? And the tool you use for this is the DG16 probe. Another bullet point where we often find ourselves perplexed is whether there is a single distal orifice or there are two distal orifices in mandibular molars. Photograph 1 is a photomicrograph of a mandibular molar which shows two mesial orifices, the mesiobuccal and the mesiolingual, and a distal orifice. The line bisecting, the imaginary line bisecting the mandibular molar in a mesiodistal direction divides the mandibular molar practically into mirror image of each other. If you clearly see, the mesiobuccal orifice is at a line at a distance equidistant from the mesiolingual orifice from the imaginary line bisecting this tooth in the mesiolingual direction. At the same time, they are also on a straight line. How does this help me in location of the orifice? In a calcified tooth, if I have located the mesiobuccal orifice, I simply have to look for the mesiolingual orifice on a straight line bisecting the imaginary mesiolingual line passing through the center of this mandibular molar at the same distance on the other side. I'll be sure to locate the lingual orifice. Coming to the distal. In the distal, many a times you find a single oval large orifice which gives us an inkling that this could be a single orifice in the mandibular molar. If you have a small rounded orifice, look at the image 2, on one side of the imaginary line bisecting the tooth mesiodistally, you are sure to find another orifice on the lingual side of this line equidistant from the line as is the distal buccal. This is called the law of symmetry, which helps us locate and know whether we have a single distal canal and orifice or two distal orifices. The law of mirror images or the law of symmetry helps us in mandibular molars. And of course, the DG16 probe, one small addition to your armamentarium to locate canal orifices without difficulty and with ease. Bullet point 4. Access management in vital versus non-vital teeth. Why have I put this bullet point here? Many a times we manage a vital tooth and a non-vital tooth access cavity similarly, but there is a huge difference here. In non-vital teeth, usually there is little to no bleeding upon gaining access. Therefore, vision is very good. The first irrigant to use in such an access cavity is 3 to 5% warm NaOCl, that is sodium hypochlorite. How does this help? Hypochlorite, being a bleach and a pulp tissue solvent, not only cleanses the access cavity but also lightens the access cavity such that it starts showing us the floor anatomy very clearly. The challenge of orifice location is not as big in a non-vital tooth access cavity as much as it is in a vital tooth access cavity, where we encounter large amount of bleeding or vital pulp within the access cavity itself. My recommendation, never rush to locate your orifices in an access cavity where you do not have clear vision. Clean the access cavity first, such that the floor of the access cavity is very clear to you, and only then start orifice location. So how do you manage this bleeding access cavity in a vital tooth? Step number 1, you introduce EDTA gel into the access cavity or the pulp chamber and wait for a few minutes. Very few of us know that EDTA gel, in addition to being a lubricant, is also an agglutinizing agent which clumps the pulp tissue together. The bleeding pulp clumps together and forms a glue-like mass, which can then be excavated very easily with an endodontic excavator. Once bulk of the pulp tissue has been excavated from the access cavity, the bleeding is more or less controlled, and then you can flush your access cavity with warm 3% or 5% sodium hypochlorite as you do in a non-vital tooth. This one simple tip of introducing EDTA gel into a vital tooth access cavity will go a long way in controlling bleeding and achieving vision in your access cavity. So your clean access cavity is going to look something like what you see on the image. Can you see and notice that the orifices are very clearly seen? The dentinal map is very clearly evident on the floor of the access cavity. The dentinal map also gives us, and it's a map which helps us locate or gauge the position of the orifices. The orifices are located at the ends of the dentinal map, which is seen very clearly in the floor of the access cavity, simply because you clean the access cavity, you spend some time rinsing the access cavity with warm 3 to 5% sodium hypochlorite in order to have a bleached and cleaned access cavity for vision. Bullet point 5. In modern endodontics, it is recommended to follow a crown down protocol or a hybrid protocol. We have stepped away from the traditional step back technique where we used to approach the apical third first and then move towards the midroot and then to the coronal third of the canal. In modern endodontic practice, we recommend that you work from the crown of the tooth towards the apex. As you see in the image, The root canal system is divided into two parts. One is the pulp chamber in the coronal of the tooth. The second is the root canal within the root. The root canal within the root of the tooth is again having divided into three parts: the coronal third, the middle third, and the apical third. When we work with the crown down technique from the crown to the apex, we address the coronal third of the root canal first, then the middle third of the root canal, and then the apical third. So, the enlargement of the root canal system also is done in the coronal third first, followed by the mid-root and the apical sections. What is the advantage of using the crown down technique, or why is it that we recommend the crown down technique or the hybrid technique for rotary preparation? If you see the images on your screen, image 1 shows us the root canal system in 3 dimensions. It's no longer a tooth with 3 separate root canals. You have so many anastomosis connections between the mesiobuccal as well as the mesiolingual, as well as the distobuccal, the distolingual. It's not like you're dealing 3 separate tunnels. You are dealing with an entire system which is present there. Look at the image 2. This is an enlarged view of the apical third of a maxillary central incisor. Can you see the ramifications that exist in the apical third? Would you call this a root canal or a root canal system? I would call it a root canal system. And how do you think are we going to clean this root canal system? Simply by addressing the one principal canal with one single rotary instrument. We cannot do that. Therefore, when we use the crown down protocol, we are basically making space for the irrigants to enter the root canal system, because it is the irrigants which are going to clean the entire root canal system. They will reach the areas where no rotary file or no hand file can ever reach. When you follow the crown down protocol, the first step that I recommend you do is opening up of the orifice. I touched upon this while we did the modification in access cavity. The triangular lip of dentin that you see here, which is present right at the opening of the root canal, which we call the root canal orifice, often hinders the entry of the rotary file. This triangular lip of dentin is simply removed by instruments like the Gates clearing drill or the piezo reamer. Alternatively, you can use the rotary orifice openers to do the job. Opening up of the orifice converts a difficult entry into the root canal system into a straight line access up to the middle third, facilitating entry of the rotary file. In addition to armamentarium, what is the cost that I need to add to my root canal? It is simply the cost of using one Gates Glidden drill or one piezo reamer to open up the orifice, or your orifice opener, which is provided with all the standard rotary systems on the market today. When you follow the crown down or the hybrid protocol, this is the single most important advantage that you gain. That is the increased volume of irrigant. If you see in the image, when you do a rotary protocol with crown down, you have enlarged the coronal to middle third and given it a funnel shape. This is an exaggerated diagram for understanding. But once you create this funnel shape, the entire funnel is full of irrigant at all times that you're working in the root canal. And every time you work any rotary file into this shape, which is filled with the irrigant, you pump the irrigant into the complex apical third and clean it in 3 dimensions. When you achieve 3-dimensional irrigation, only then can you achieve 3D obturation. So if you look at the photo micrograph again here, you can see the root end. This is the root end with the principal foramen, and you see multiple foramina or accessory exits to this root. However, how are we going to clean all of these exits? The only thing that can clean these exits is your irrigant. And how would your irrigant best reach these exits? Simply by following a crown down or a hybrid protocol, which allows for a large volume of irrigant to be held in the root canal system. Once you have a large volume of irrigant and then you shape the root canal system with your rotary file with that volume of irrigant, all your lateral canals are cleansed and filled, and you will notice on your obturation that all the portals of exit of the root canal are cleaned and sealed, which will give you a three-dimensional obturation and ultimately a successful root canal treatment. Another example where you can see that the sealer flows in various directions. Where is it flowing out from? It is flowing out from an accessory canal and an additional portal of exit. You have multiple portals of exit. If you see the radiolucency in this particular tooth, you have a radiolucency right all around the tooth. It's not just a periapical but even a lateral radiolucency. Remember, your portal of exit always points to the lesion of endodontic origin. So if I have a lesion here, I must know that there has to be an exit here. And the only way to address this exit is by using three-dimensional irrigation and the crown down or the hybrid protocol, which allows us to hold large volume of irrigant within the canal system. Another example, look at the first molar in this case. This is an example of an angled radiograph which shows you the MB2 separate from the MB1. And you can see that the two canals have two separate portals of exit. In these cases, it is very important to address both the portals of exit separately. Otherwise, you can have or land up with a failed root canal treatment. Bullet point 6 of today's webinar: heat-treated nickel titanium advantage. What do I mean by the heat-treated nickel titanium advantage? Currently, we are in the second generation of nickel titanium rotary files, and my recommendation to all of you in your modern endodontic practice is to start shifting from the generation 1 nickel titanium files to the generation 2 nickel titanium files, which are the heat-treated nickel titanium files, rotary files. And what does heat treatment do to the rotary files, or what are the benefits of this new generation nickel titanium rotary files? The first advantage is they can negotiate severe curvatures. They can remain centered in the canal. They allow optimal canal adaptation and have excellent resistance to cyclic fatigue. So how has this been achieved? What have they really done in the new generation nickel titanium rotary files? They are also called the heat-treated rotary files. What has been achieved is these files have been manufactured at a different phase of the nickel titanium alloy. Nickel titanium alloy exists in two phases, as all of us know, the austenite and the martensite phase. So the new generation nickel titanium rotary files are manufactured in the low temperature martensite phase. Having done this gives the big advantage of removing the spring back or the shape memory of the nickel titanium files. Once the shape memory of the nickel titanium files is controlled or removed, the nickel titanium file does not keep springing back to its original position, but follows the curvature of the canal more steadily and remains centered in the canal. Therefore, controlling the shape memory of the nickel titanium files or reducing the spring back of the nickel titanium files is the single big advantage of the heat treated or new generation nickel titanium files. So my recommendation is wherever you are in your rotary endodontic practice, preferably shift to the new generation heat-treated nickel titanium files which have less spring back or controlled shape memory. So when you have one of the files, and I follow and use these files in my practice, they are the HiFlex CM controlled memory. HiFlex CM, CM stands for controlled memory. These files are by Colty in Dent, and these files are the second generation nickel titanium files where the shape memory has been controlled, because of which severe curvatures also can be very readily prepared by your rotary file. Rotary file will follow the curvature of a severely curved canal without having a spring back that causes zipping or ledging of the canal. Abrupt curvatures can, and at the same time the file remains centered in the canal. My bullet point 7, E-apex. My strong recommendation to all of you here on this webinar, if you want to incorporate modern endodontics in your practice, you have to invest in an apex locator. An apex locator is the single device or the only device which can accurately record your apical constriction or point A as you see on the image in front of you. Can everybody see the image? Hello? Yeah.
No.
Is the image visible on your screen?
Yes.
Yes. Okay. So the apex locator, if you look at the image very carefully, in modern endodontic practice, wherein we mean rotary endodontic practice, all our shaping protocols with our rotary files have to end at point A and not point B. When we take a radiograph, what we see on the radiograph is point B and not point A. So we arbitrarily subtract 0.5 millimeters on 1 millimeters and take that as our working length. This is what we traditionally do. But the apex locator is a device which will help you to record point A to an accuracy of 98%. The point A is the point of narrowest diameter in the entire root canal system called the apical constriction, and this is the point at which all your rotary protocol or rotary shaping procedures and obturation should terminate. My recommendation, invest in an apex locator which is the only device to record point A, such that you do not overwear your canals with your rotary files. One common problem that I observe or see nowadays with the advent of rotary shaping is over-prepared canals. People land up with post-operative flare-ups, post-operative pain and tenderness in seemingly well-obturated cases. And you know what the reason is? They have prepared the canals with the rotary files to point B instead of point A. An apex locator used correctly will definitely avoid this mishap. So my bullet point, use an apex locator to locate the electronic apex and then expose a radiograph at that length to confirm the working length. Bullet point 8 for today's webinar, patency filing between rotary instrumentation. What is meant by patency filing? Patency filing simply means number 10 hand K files are passed gently 0.5 millimeters beyond the E apex or the electronic apex as recorded by the apex locator between every two rotary files that are introduced into the root canal system. What does this help in doing? It simply keeps the area between the point A and the point B of the earlier image patent or clean. This is the area where the debris which is created by a rotary instrumentation may go on and block. Once you block the critical apical third or the critical apical 1 millimeter with your own debris created by a rotary instrument, you have already lost your working length, and it's very, very difficult to then again find your portal of exit. One simple step that can prevent blockage of your apical foramen is patency filing, done simply with your number 10K file, passed gently 0.5 mm beyond the E apex, that is beyond point A, between rotary instrumentations. If patency filing is not done, many problems that we encounter. Number one, the foramen gets blocked. There is frustrating loss of working length. How many times do we get the working length correct in the beginning, but by the time we reach the stage of obturation, our master cones are 1 mm short or 0.5 mm short of the original working length? This is simply because patency filing was not done. The second last bullet point of today's webinar: have a final irrigation protocol before obturation of your root canal system. What does the final irrigation protocol help achieve? The final irrigation protocol helps achieve complete three-dimensional irrigation and flushing of complete root canal system with a series of irrigants before you finally obturate it with your gatapacha and sealer. When is this protocol done? The final irrigation protocol is also called as active irrigation done before obturation. This protocol is done after your master cone is selected. It is done strictly under isolation with a rubber dam. Fill the canal with 3 to 5% sodium hypochlorite, warm hypochlorite is preferred, and agitate the irrigant within the root canal system with your last file used or with sonics, ultrasonics for a minute. You can use any sonic or ultrasonic instrument for this. An example of the ultrasonic instrument can be your Orifice files from Satellac. You have sonic instrumentation, as well as if you do not have a sonic or an ultrasonic instrument in your clinic, you can still do this protocol using the last rotary file that you used within the canal system. Once you agitate the canal completely, the NOCL completely in the canal for a minute, you dry the canal with greater taper paper pints. Fill EDTA wash. What is EDTA wash? Nothing but liquid EDTA, 17%, is next filled into the canal, and it is again agitated for another minute. So 1 minute of 3 to 5% sodium hypochlorite is alternated with 1 minute of liquid EDTA 17% and agitated for a whole minute. What does this do? The agitation of the sodium hypochlorite within the canal system flushes out any remnants of organic and inorganic debris which are left behind in the canal system or the lateral canal system, the lateral exits. Liquid EDTA brings this debris into solution. It softens the dentinal wall and removes the smear layer which is created by rotary instrumentation, thereby giving us a clean root canal wall surface for the sealer to flow against. You alternate sodium hypochlorite and liquid EDTA until clear liquid is seen in the access cavity. Initially, when you alternate this for a minute each, you see a lot of cloudy colored liquid coming into the access cavity. Repeating this procedure 2 or 3 times will help you find clear fluid in the access cavity, which is an indication that your active irrigation protocol is now complete. Finally,